My topic is preoperative evaluation. So, always the preparation of TKR journey starts by admitting in a OPD basis and it ends at the door of the operation theatre. So, evaluating, getting a good history, examining the patient properly is very important factor of that. So, patient's meeting starts with a basic history of about age, sex, habits like smoking and alcohol needs to be maintained. Complaining of pain, so various of pain the patient comes with needs to be evaluated. Deformities, what are the repetitions of knee motions or crepitations going on, any locking mechanism or repeated knee swelling needs to be considered. Along with it, history of previous any medications, any physiotherapy or exhausted treatment taken, any generalized joint diseases, any previous history of UTI, DVT needs to be considered before going into operative things. Plus the social conditions and expectations, what the patients come with or what the patient expectations are about kneeling for praying or a manual labor to be considered before deciding which all implants or how the surgery need to be go out. So analysis is very important depending upon the age. Is it post-traumatic or inflammatory or markedly deformed? We need to consider about which our planning, how the planning will go ahead. Genders needs to be considered because of the activities. Level of activities need to be considered because to look out for the longevity of the implants and the better surgical end. So pain needs to be considered, analyzed on basis of if it's disabling, a patient is able to walk with a stick or assisted devices. Is it relieved by medications and rest, or is the pain is with at rest also like a night pains? Depending upon how much failures of previous trials and conservative management is there, need to exclude all the other causes of pain, like a claudication pain. The pain may be because of any spine or hip or any other joint things which is radiating to the knee. Analyze the complaints on basis of chronic knee inflammation to rule out any infections or other things. Deformities, depending upon if it's inflammatory or traumatic, how much amount of this, and expectations of the patient should be restored to the reality. So the patients should be told that the operation is to reduce pain, improve function, and improve quality of life. That's it. Not that the high expectations need to be given to the patients. Following the history and the examination comes in standing. First of all, to look out for the posture, which is the varus or valgus deformities, any sagittal flexion or recurvatum is there. Followed by looking for the center of the patella. You can calculate with the goniometer if you have. Examination depending upon the thrust. The gait is the one important thing needs to be considered when the patient walks into your examining chamber. You should need what type of gait is there. Is it a varus thrust or a valgus thrust? Is there a hyperlaxity which is seen? The patient walking with a fixed flex deformities or antalgic gait. Need to examine other joints like if the patient is having a flat foot or things. Weight and BMI needs to consider because depending upon that, the results and the complication rates are analyzed. Examining in the supine to see for any skin scars, previous infections or previous surgeries, amount of muscle wasting or VMOs needs to be analyzed. Supine gives a proper examination of any flexion deformities, any flexion contractures, any hyperextensions, any skin disease or the back of the knee. You can see a swelling or scars like a popliteal cyst or any popliteal bursa is there. Palpation to see any sign of warmth or skin hotness. Bulge to see any effusion is there. Second, as we know, palpation helps in knowing the crepitus joint line tenderness. Is it the joint line tenderness because of any meniscus injury, or is there is a pes anserinis tenderness to see for any deformities and rotational thing. Range of movements needs to be calculated initially so that we know a preoperative range of movement, how much it. Is it restricted? Is it limited? Or if there is a hyperextension, how much amount of hyperextension is there? If there is a lack of extensions, if there is a flexion contracture, and patella should be facing always towards ceilings when you examine it. It should not be in a rotation mode. Special tests need to be performed to see for a laxity of any other ligaments. So we should not miss any correctability or reducibility is seen. So degree of corrections of the varus or valgus thrust can be analyzed to see if it is a correctable or not correctable deformity. Neurovascular status in the end we should check for. So depending upon the neural status, if to use a tourniquet or not, conditions with varicose veins or varicose ulcers are there, so need to be evaluated. Examination of other joint is very important, so that if there is a flexion deformities, initially you can manage the walk or gait or prevent any other flexion deformities if there is a delay in the surgery. Upper limb for the post-operative rehabilitations need to be seen. And lumbar canal stenosis or other spine complaints needs to be managed, can be managed before going for a surgical things. Scoring system, different scoring system can be used depending upon a patient reported outcomes or observed reported outcomes, like knee society score or a WOMAC score, to evaluate a pre-operative status of the patient. Next, the investigations which commonly used and followed is the X-ray. So X-ray in APA in full extension, standing views, patella facing forward is usually the ideal things. To look out for a joint space of more than 4 mm or less, or within 50% of the joint space of the opposite limb is seen. Lateral joint space, if wider than the medical space is there, any osteophytes or subachondral changes or sclerosis is seen on X-rays. Lateral views helps to give us idea about any patella alta or patella infra is there. It helps in identify any loose bodies in the posterior compartment or osteophytes. Templating can be done. Patellofemoral versions view help in finding about patella tracking or patella tightness or patella tilting is there. Other views which helps in planning the TKR is the full length hip to ankle view or a scanogram to see any extra articular deformity is there, or a tibio-femoral angle plus templing is required. Joint space narrowing typically gives location of the cartilage wear on a Rosenblum. Supplementary views like a tunnel view for the posterior surface, OCDs or loose body can be taken, and followed by CT or MRI, which helps in assisting us in a robotic assisted TKRs nowadays, which we require, plus giving any other information about that. Various classifications of radiology are there. So templating is the next person which help us in diagnosing or identifying the size of the femur or size of the tibia. The exit point usually is along the femoral axis where it cuts the femoral trochlea. Okay, so posterior tubular slope can be helped. So there are various commercial templates which will be available with whatever system you follow or you use. Next is the laboratory investigations which we go over. So routine investigations as a hemogram or liver or random blood sugar, urine analysis and MRC screening can be done with ECG and cardiac fitness to be done. Additional vitamin D levels, screening of viral markers and nicotine levels is everything. So prerequisite for any against infection or wound problems, the hemoglobin should be more than 12, HbA1c which should be less than 7, albumin levels, transferrin and lymphocyte levels should be marked. Optimization of the patients before TKR is very important thing. So 2 tracks, optimization of the medical conditions and optimization of the physical conditions is required. So better outcome helps into happier patients and happier surgeons. So various risk factors, as we know, is there are modifiable and non-modifiable risk factors. Modifiable risk factors like allergies, inflammatory changes. So how to deal with the modifiable patient? So any amount of poor dentitions need to be managed before. Any BMI more than 40 needs to be treated for long-lasting implants. Any DVT or PE infections should be looked out. Smoking needs to be reduced before. Hemoglobin and HbA1c need to be managed, so endocrinized reference and control of the sugar is widely required. Any malnutrition to be treated. MRSA is commonly found and it needs to be managed before. So decolonization procedures in case of patients of active infections needs to be done. So any boils to be drained, antibiotics need to be treated. No chronic intravenous devices is advocated prior to the surgeries. Urinary catheters to be avoided. Colonization eradication should be attempted at home, not to be included in the hospital, with chlorhexidine wash or antiseptic bath. The patients who are positive for MRSA needs to be treated with mupirocin 2% ointment applied in each nostrils before 7 days. Oral antibiotics are not required. Encourage treatment with all household members, and post-treatment surveillance may not be required. As we know, UTIs should be treated aggressively before. The patient with UTIs should be restrained from surgery. Cardiac problems needs to be managed. 5 minutes, 2 minutes more. Any create problems to be managed before, so that optimization of the patients is required. Hemoglobin should be above 10. Vitamin deficiency less than 20% has increased risk of aseptic loosening and infection, so need to be managed before prior surgery. Any antiplatelets to be stopped 7 days prior to the surgeries. Steroids and methotrexate can be continued along with that in proper dose. But if the patient is not able to tolerate without methotrexate, can be stopped 7 days before for proper healing. So it all ends with the patient education. So exercises, pre-rehab, fluids intakes, decrease smoking and proper care with other personal aids to be managed at the home helps into a better outcomes with happier patients, happier surgeons, and lesser of readmission levels. Thank you very much.